All right, so we're going to talk about toxicology here. I could probably talk about this for at least 10 or 12 hours, so you guys stop me if I go on for too long. But this is my baby. This is what I went to fellowship for, so I did 2 years of this doing emergency medicine and Clintox, and so I'll talk a lot about poison centers and things. Do you guys know where your poison centers are located? Jacksonville? Yep. Yeah, on the phone there. That's where they're located. So in Florida, we have Jacksonville, we have Tampa, and then we have Miami. So depending on what area code you're calling from on the phone, you will get the corresponding poison center. So even though technically this is a Tampa area, if I call from my cell phone, which has a Jacksonville area code, it will go up to the Jacksonville center. So sometimes we get calls kind of misrouted, and so you have someone who's like, a snowbird or something calling up, and they really need to go to like the North Dakota poison center or something, and they come to us. But so do you know who you talk to when you call the poison center? Possibly me.
Doctors and nurses and stuff too, right?
Doctors and nurses and stuff, mainly. So you're going to find that most of the time, at least in Florida, we mainly have nurses that staff the phones. And so we call them specialists in poison information. So if you ever hear me talk about spies, that's most likely what I'm talking about and not my other side businesses. We don't call them poison information specialists because no one wants to be called PIS. But yeah, so mainly they are nurses who are coming from a kind of critical care or an emergency medicine background, and so it's good for them, and they're kind of the twilight of their career, where maybe like being in a busy ER is not like their preferred place to be, and they're like maybe not quite so mobile. So it's good if they have any kind of physical impairments or anything like that. They come over to the poison center. It's a nice cushy desk job for them. And basically we field calls from kind of all comers, right? So if you're a mom and your kid gets into the Tylenol, they call us up. We can handle those calls, right? And we also get calls from the hospital. So if a doc is seeing a patient, they say, what the heck is this? I don't even know what's going on. Here's how the patient presented. Here's the history. Then we can kind of guide them through it and figuring out, okay, well, it could be this, or this. Probably not likely to be these things. Let's try these antidotes, etc. You'll find that you can request toxicology consults, and that will go to the toxicologist, right? So you have the poison information, the specialist there you'll talk to initially, and then they can talk to the toxicologist. That will usually either be a pharmacist. We have several PharmDs, toxicologists here in Florida, and then there's always a medical director for the poison center. So a medical toxicologist you can also possibly speak with, and so they're kind of ultimately responsible for kind of like the license for the poison centers and whatnot. But anyway, it's a very good service. It's totally free. There's lots of good data to show we're kind of a big cost savings kind of thing. So if you can prevent one ER visit, that's a huge cost saving, and we do that very frequently. Sure enough, there are still parents that say, poison center said I didn't have to come in, but I wanted to come in anyway. But it's okay, well, now I got an unnecessary ER charge, but whatever. But yeah, so it's a very good service. So if you get a chance to call up the poison center, does anyone know the number? It's very easy. It's 1-800-222-1222. You can call us up even if you have a kid that gets into something. That's totally fine. But from a hospital setting, we do get a lot of calls from providers, asking like, what the heck is going on? That's going to be one of the first things we'll talk about, is how do you determine what a patient could have been exposed to in a toxic exposure. So we're going to talk about toxidromes, kind of just a combination of toxic syndromes. Basically, these are just the signs and symptoms that someone should be presenting with when they have an ingestion or an exposure to something. And very frequently, the history is oftentimes misleading in a lot of these patients, to where I don't want them to even tell me what they think they ingested. Just tell me how they're presenting, because a lot of times you can find kind of red herrings. If the patient comes in and they say, hey, they had an empty bottle of oxycodone next to them, but they're coming in and they're screaming and they're fighting the staff. That doesn't sound like an opioid, right? You have to find things that are consistent or not consistent with their presentation. So this is how toxidrome is going to help us out with that. So again, this is basically going to be just these constellation signs and symptoms that go in to say, okay, this is what an opiate should look like. This is what an anticholinergic should look like. If you ever hear me talk about toxins or toxicants, really the only big difference there is kind of where the kind of the category falls into. So toxins are natural sources of substances. So these are things like botulinum toxin, we use for therapeutic purposes as well. Snake venom is a toxin, and the toxicants is kind of everything else. All of your drugs, things like that, are technically toxicants, but you'll hear me kind of use them interchangeably. So there's the list that we'll cover. So you may have questions on the test, and again, this is not strictly going with like the therapeutic use of drugs, but if someone does have an overdose, or either whether it be iatrogenic, we did it to them, or they're using for abuse purposes or accidental ingestions, you should be able to recognize what kind of toxidrome the patient is presenting with. So if I said, hey, this patient shows up X, Y, and Z, what toxidrome is the most consistent with their presentation? You should be able to kind of figure that out. Have you guys covered these before? Some of them we've covered in this class, but has covered this topic specifically. the blank stares means a no. So the first one we'll run into is going to be cholinergic poisoning. Do you guys know any places where you might run into cholinergic poisonings? What type of substances, I guess? Pesticides is a big one, right? So we have specifically organophosphate pesticides are a big one. A lot of nerve agents. So if you think about chemical warfare, a lot of nerve agents will also kind of fall in this category of causing a cholinergic toxidrome. We don't run into this one super commonly, in the clinical sense, but it's good to have this one down so that way you know what it looks like, so that way you know what the opposite looks like as well. But things like malathion, parathion, yes. Okay, yeah, so sarin gas. Yeah, absolutely. So sarin gas is a very common one, like VX nerve gas. You guys ever seen the movie The Rock?
Yeah.
Yeah, you know how like they have the little balls and that like the guy's faces melt off? That's not actually what happens. I was very disappointed to figure that out. Apparently movies lie or something, but anyway, you'll definitely have liquid coming out everywhere, but the faces are still going to stay pretty much in place. But yes, yeah, so you may see that in the news, because this is a very common way for terror attacks and things like that to be held out. There's been cases where there was like this weird cult in Japan where they actually released sarin gas on a subway, and so certainly can have a whole course in chemical warfare and things like that. But yeah, so very commonly these cause a cholinergic toxidrome. But again, organophosphates are probably the most common ones you run into here in the States. Fortunately, we've moved away from a lot of those because we have better, safer pesticides. You see a lot of things like pyrethrins, permethrins, things like that. Whereas if you go to more developing countries, you'll find that that's still a very cheap and very effective pesticide, and they use it very frequently. And this is a very common way that a lot of people will try to commit suicide. So if you go to places like India, they have a large number of people who try to commit suicide with these. You have a bad crop one year, your family can't pay for your family that year, basically you say, okay, I'm just going to drink all this. And in a lot of cases, they don't have enough ventilators in some countries to actually support the number of people needed for these poisonings. Okay, so it's a very big problem in other countries than here, but you can still run into it occasionally. And then we also have some agents that we use therapeutically. So if you guys remember when we talked about our paralytics, we talked about the non-depolarizing neuromuscular blockers, you guys remember how we reverse those? Used acetylcholinesterase inhibitors, right? Because we wanted to increase the amount of acetylcholine that was available. They'd kick off the paralytics off the receptor and then kind of reestablish normal transmission there. We can use these therapeutically, so things like neostigmine, physostigmine, we use occasionally. So we'll talk more about those later. But also some things that can cause nicotinic symptoms. You can see things like nicotine. So nicotine poisoning can be a very big deal for kids if they ingest cigarettes. Obviously, the e-cigarette issue can be a big deal, especially those refill liquids. Not a lot of regulations on those, so there's no childproofing on a lot of those bottles, and very concentrated nicotine. And then the sarin, soman, and tabin are the nerve agents that we kind of alluded to being used in Syria. Okay, so how do these agents work? Essentially, you have acetylcholine floating around in the CNS. There's going to be activating both nicotinic and muscarinic receptors, right? And how does acetylcholine get broken down? Acetylcholinesterase, right? It's a very fast enzyme. It works very, very well. Basically, what you end up having is that these agents will come along and bind to the acetylcholinesterase and prevent them from working. Okay, this can be a reversible phenomenon in the case of things like neostigmine, or these can be an irreversible phenomenon. And so, a lot of these agents undergo what we call aging process, where if they stick around on the acetylcholinesterase for long enough, they form a covalent bond. And then once that occurs, then you're kind of out of luck, right? Because then you need to generate new acetylcholinesterase in order to start to break down that acetylcholine again. But essentially, if you prevent this from occurring, you're going to have excess levels of acetylcholine. That means you're going to have excess activation of both nicotinic and muscarinic receptors. So kind of see here how this process can occur. Here's an organophosphate binding to the acetylcholinesterase, and eventually once that aging process happens, this is a covalent bond. This is irreversible. And so we really try to prevent this by initiating therapy early on in order to kind of save the acetylcholinesterase, because your body only regenerates about 1 to 3% per day. So if you have a total, if you wipe out all of the acetylcholinesterase, it takes a lot of time before that can start to really, get back to a normal baseline for that patient. So again, organophosphates are irreversible, but the carbamates we mentioned, like neostigmine, physostigmine, those are reversible, which is why we can use them clinically to help reverse things like the non-depolarizing neuromuscular blockers. So the old way we used to remember the muscarinic signs and symptoms of cholinergic poisoning was sludge, but this misses the killer bees, which I always mention. So the new mnemonic is, yeah, dumbbells. So basically we use dumbbells. So you have the defecation, urination, meiosis, right? So you're going to get tiny pupils, bradycardia, bronchorrhea, and bronchospasm. Those are the killer bees. Like I said, no one's ever going to pee themselves to death from cholinergic poisoning, but certainly your lungs can fill up with fluid. You're not able to oxygenate appropriately. You get bradycardic. You're not perfusing. That's the big things we're worried about. Emesis, lacrimation, salivation. Okay, so being they're going to have liquid coming out of every single orifice possible, they're incontinent, it's very kind of messy kind of poisoning. So the few times you've run into this actually coming in, you'll put a Foley into them and they're just generating liters and liters and liters of fluid. So again, you have to replace all that as well. So they do require a lot of fluids to keep them kind of tanked up. You can also see the nicotinic signs as well, and so this can be confusing for some people because you expect to see them just to be, meiotic and bradycardic and just losing fluids everywhere. But you also have these nicotinic signs that can show up kind of early on, because again, the acetylcholinesterase is not specific for one receptor type or the other, but typically you'll see nicotinic signs early, and then eventually the system gets overwhelmed with more of the muscarinic signs. So the way I remember this is going to be the days of the week. So I think mydriasis, I think tachycardia. You have weakness, say hypertension for HERS day, it's the closest I could get. And finally, you have these fasciculations that can happen, right? So those nicotinic receptors on the neuromuscular end plate get activated, so you see those fasciculations very similar to what drug we saw a lecture or two ago. It's a paralytic, depolarizing neuromuscular blocker. Succinylcholine. All right, so this is the same thing that's happening here. So succinylcholine, you saw those fasciculations because you're overactivating those nicotinic receptors. Same thing happens here. You get fasciculations. Eventually, you wear out those receptors. Eventually, you can end up leading to this diaphragmatic paralysis, right? So that's a big thing you worry about. Is one, their lungs are going to fill up with fluid. They get bradycardic, and then also these muscles are going to start to wear out, and they're not going to have a good respiratory drive. So this is the big thing we are trying to prevent. We can support them, right? We can intubate these patients and breathe for them, but again, it takes a long time for that acetylcholinesterase to build back up, so we like to avoid that as best we can. Some other things you might see from cholinergic poisoning include like headache, confusion, some slurred speech, ataxia. Then also you can see seizures with this. So this is another common set of drugs that can cause seizures. So we'll talk about treatment of that in just a little bit. But again, just always remember when you have drug-induced seizures, the treatment of choice is going to be, does anyone know? Benzos, right? It's always going to be benzos. We don't like to use drugs like phenytoin. Valproic acid is not really going to be that useful. Capra is not that useful. Really, benzos is the best way to go. And then if that's not working, we can use things like barbiturates, like phenobarb, pentobarb, or we can use things like propofol. Right? We mentioned that back in the sedative lecture. You can also use that as an anticonvulsant as well. How do we support these patients? For one, ABCs are really important. So again, airway support, make sure that they're able to oxygenate appropriately. If you need to secure an airway for them, you do that. A lot of the organophosphates also come in kind of a hydrocarbon base, usually some kind of oil type distillate. And basically the one thing we can run into that is that the patient aspirates that, right? So again, they're having emesis, so there is a risk for them to end up aspirating that, and then it can cause kind of a chemical pneumonitis in the lungs, which again could be kind of more complicating their picture there. You do want to be careful with these agents because they are lipophilic, which means they can be absorbed through the skin. I actually had one of the paramedics I work with, his daughter actually had really bad lice, and so they'd gone through a couple of cases of permethrin, still nothing, still had nits everywhere, and still had really bad lice. So he said, well, I'm going to get this malathion shampoo, and so malathion is one of those organophosphates we mentioned, and sometimes we'll use that for more resistant lice, and the pharmacy was going to charge him something like $200 for the shampoo, and he's like, well, I'm not going to pay that. So he decided to go to the hardware store and picked up some malathion, and he was going to go ahead and dilute that himself and give it to his daughter. And he's like, telling me about it, and I was just like, he's like, it basically came as like a 5% solution. He had to dilute it down to what the actual drug product would be with isopropyl alcohol. And I was like, hey, you didn't do this, did you? He's like, oh yeah, I already did it. I just wanted to tell you about it. And I was like, ooh, okay. He did it appropriately, and his daughter actually ended up doing fine. No more lice, so yay. But had he done that incorrectly, you could absolutely see skin absorption of that and end up causing, she would have been having a lot of lacrimation, would have had a lot of salivation, things like that. And he said, nope, still not spitting everywhere, so must have worked. So as far as antidotal therapy goes, we have a couple of drugs that we can use here. One, we have atropine. You guys remember how that drug works? It's a muscarinic receptor antagonist, right? So if you needed to dry out the lungs, if you needed to increase the heart rate, atropine's a drug to go to, right? Because you're blocking those muscarinic receptors, which we know are being overactivated. It's just competitive antagonism. So you just give a big enough dose, you'll kick that drug off of the receptor and reestablish normal activity. So atropine is going to be good for muscarinic symptoms only, right? It's not going to fix the fasciculations, the hypertension, the tachycardia. If anything, it will cause tachycardia, right, because it's a vagolytic. But certainly this will work for the muscarinic signs. Okay, and so one of the things that we do as far as our endpoints go for giving atropine is that some people say, well, you give it until they're tachycardic. It's not really the case. We don't care if they're really tachycardic so much, but we give it until they have clear breath sounds, right? You want to make sure that the lungs are dried out enough to where they're able to oxygenate and exchange air appropriately. The other drug that we can give is called pralidoxime or 2-PAM. This drug is the drug that we give to irreversible acetylcholinesterase inhibitors because this actually prevents the aging process. I'll show you a picture of that in just a second. But this is the actual antidotal therapy, and it's really important that we get this on board as soon as possible in order to make sure that we prevent that aging process from occurring. We want to save as much of that acetylcholinesterase as we can. So we give that. It'll actually bind to the organophosphate and just let it be eliminated through the liver, through the kidneys, and kind of save that acetylcholinesterase so it remains effective. And then, as I mentioned, for seizures, benzodiazepines are going to be your drugs of choice. So what are some good examples of those? Lorazepam's a good IV one for seizures. What else could I use? Diazepam's another good one. Yeah, Versed IV, so midazolam is another really good option. So those are your three kind of main IV options that you can use for treating these kind of emergent seizures. Barbiturates, like you mentioned, so phenobarbital, pentobarbital are all good options, and the propofol we might use occasionally as well. So those are all good ways to end up treating those seizures. Again, using the atropine, really just use it kind of on an as-needed basis. You don't have to remember the dosing here. I'm not going to quiz you on that, but really just trying to dry out those excess pulmonary secretions. And in some cases, we actually end up having to put patients on atropine drips just because they require such frequent redosing. And if they come in kind of late presenting, they could be so overtly cholinergic they need a drip in order to keep them kind of at a stable point. And then I mentioned the pralidoxime. This one you can give as a bolus and then you run as an infusion afterwards. And it's really just meant to save the acetylcholinesterase for as long as possible. Basically what you end up doing is you kind of treat them with the 2-PAM until you don't really need any more atropine to control those muscarinic symptoms. And then at that point, once it's 12, 24 hours out, you can say, okay, we're probably good. We've probably cleared the rest of that organophosphate. Now let's go and titrate down the 2-PAM. If they have symptom recurrence, then you're still dealing with the poison sticking around, so then you have to kind of reinitiate that 2-PAM at that point.
Sorry, did you say that atropine is an antagonist?
It's an anti-muscarinic. Antagonist, yeah. Antagonist at the muscarinic receptors. Okay. Absolutely. So then moving on, so then you have the flip side of this, and this is something we see much more commonly, is going to be our anticholinergics. Okay, so several places where you can find these. There's some plants that grow here naturally in Florida. You have things like your belladonna alkaloids, which includes plants like Jimson weed, angel's trumpet. Does anyone have like angel's trumpet growing in their yard or their grandma's yard or something? Yeah. Absolutely. So you can find certainly intentional abuse where people are trying to use these drugs in order to achieve a high, more common than you might think. And then there's also, this is done very commonly with antihistamines. So a lot of cough and cold preparations, they'll use it to get the first generation antihistamines, which have a pretty strong antimuscarinic component to it, right? So things like diphenhydramine, things like doxylamine, things like chlorpheniramine, all can be used in order to try to get some euphoria and hallucinations and stuff. But then we know there's lots of different antidepressants and antipsychotics that have a pretty strong antimuscarinic component to it as well. So think about your TCAs, think about your first generation antipsychotics. They can all manifest these anticholinergic symptoms as well. Okay. So again, they're antimuscarinics. These drugs are specifically blocking those muscarinic receptors, very similar to what atropine is doing, right? Atropine is considered one of the belladonna alkaloids, okay? You guys know what belladonna means? Where that name comes? Yeah, so I used to use it back in like ancient Greece. They used to use it in the eyes to cause mydriasis, and they used to think that was a very kind of attractive feature. I think it would look a little creepy, but that's what they did. And so basically, the same thing's happening here. We're blocking those muscarinic receptors, and you're going to cause this anticholinergic toxidrome. Note that there's really no nicotinic effects here, just muscarinic effects. So we've talked about this previously, but it's going to be red as a beet. So you can see this flushing and cutaneous vasodilation. They're going to be dry as a bone. So typically you see dry secretions, dry skin, dry mouth, urinary retention can happen here. You're also slowing down the GI tract, so you can see constipation from that standpoint. They can be mad as a hatter. So initially at kind of low doses you see CNS depression, and then as you get higher and higher doses they get more agitation, that euphoria, hallucinations, and eventually seizures, which is a big thing we were worried about. They'll be blind as a bat, so they'll have those mydriatic pupils, decreased accommodation to light, so kind of blurry vision, and then they'll be hot as a hare. So hyperthermia is going to be the big thing you're going to see there as well. Other things you're going to see is potentially tachycardia is probably a very common sign that actually can oftentimes stick around much longer than you can see with a lot of the CNS manifestations. Occasionally maybe some hypotension, but it's not as common. And then we do worry about this decreased GI motility because of the fact that, for instance, if you were to ingest a whole lot of diphenhydramine, right, and all sitting there in the stomach, and I start to absorb some of that in the small intestine, that's going to start to slow down the GI tract, and I can have a lot of drugs still stuck there in the stomach, okay? So even though patients manifesting their symptoms, they still have drugs sitting there left to be absorbed. As the patient starts to get better, as they start to metabolize that drug off, their gut starts to wake up again, and then all of a sudden they start to reabsorb all that drug that was sitting there, okay? So we really worry about delayed absorption with anticholinergics, and then also with our opioids as well. They can see that. So a patient will look like they're getting better, and they get more symptomatic as they go along. And then obviously the CNS effects, the seizures is the big thing we're worried about from that standpoint, but you can see anywhere between, you know, just mild sedation to hallucinations, agitation, psychosis, seizures. So there's a lot of different things that anticholinergics can kind of masquerade as, and so it's important to make sure you kind of go down your differential diagnosis, look for things that could be most likely to cause these kinds of symptoms, and kind of rule things out as you go along. So other sympathomimetics, so can you guys think of any drugs that we would consider a sympathomimetic? Things that are activating that sympathetic nervous system. Sometimes it's stimulants. Adderall, yep, so what Adderall falls into what category? And amphetamines, yeah, amphetamines, absolutely. So amphetamines are a big one, right? Especially if you go out in certain parts of rural Florida, you might have some clandestine labs, so they're trying to make their own amphetamines. Not that I had one in a trailer down the street from where I grew up or anything like that, but so you have amphetamines. What else can fall in that category? Methylphenidate, certainly. So just in stimulants in general. Think about like illicit street drugs. Cocaine, crack, methamphetamine, ecstasy can fall in this category as well, right? So all these things also can look very much like an anticholinergic because you're causing tachycardia, they're getting hyperthermic, they're having the CNS effects, right? So it's very difficult clinically to determine the difference between these in a lot of cases. You have to think about sympathomimetics being a possible source for their symptoms, withdrawal syndromes as well. So when you're withdrawing from opioids or you're withdrawing from benzos, right, they're very agitated, they get very, you know, get a little more squirrely, they potentially could have seizures, especially with benzos, not so much with the opioids, but you have to consider that. Neuroleptic malignant syndrome, do you guys remember what drugs cause that? Haldol's a big one, right? So your high potency D2 blockers and your first generation antipsychotics is a big one. Serotonin syndrome, we know lots of drugs that can cause that potentially. Salicylate poisoning with things like aspirin can also look like this. Sepsis, adrenergic axis, pheochromocytoma, like, you know, all these things can masquerade as you know, anticholinergic poisoning. So it's our job to kind of go through, look at the history, look at the other kind of factors involved here and see which one's most likely. But we'll find that with the treatment-wise, it's pretty easy for the most part because a lot of these are treated all very similarly. So again, when you're dealing with these, ABCs are going to be the most important thing. If we can do GI decontamination, that's going to be appropriate. You guys know what we like to do GI decontamination with? Yeah, activated charcoal. What do we used to use? Yeah, we used to try to make them throw up. We used to use Ipecac. We found that it really doesn't get a whole lot of benefit. So in a lot of cases, you know, parents will call us up to the poison center and say, my kid got into this. I tried to make them throw up. You don't want to do that, right? Because what's the biggest risk with emesis? Aspiration, right? So in a lot of cases, they cause more problems with the emesis and the aspiration than they do with whatever the drug would have done, right? So that can be one thing you want to avoid. So use activated charcoal, which is basically just has a very high surface area. It's able to bind up a lot of things. So we'll probably talk more about that later, but you can certainly use that. And really the big thing with activated charcoal is you want to use it within an hour after the ingestion, right? If it's past an hour, most of the times the drug has moved past the pylorus of the stomach. You're really not going to be able to catch up, so to speak, and bind up that drug. But for agitation and seizures, like really benzodiazepines are going to be the biggest thing. Even you can deal with a lot of the tachycardia by giving benzos. And then finally, if you have refractory seizures, or if you had refractory tachycardia and arrhythmias, you can end up using a drug called physostigmine. You guys remember where we saw that just a few slides ago?
It's one of the cholinergics.
Yeah, so it's a reversible acetylcholinesterase inhibitor. So we can actually give this in order to help increase levels of acetylcholine to kick off those anticholinergics and reestablish that normal flow, right? So physostigmine, acetylcholinesterase inhibitor, reversible. It's actually a plant obtained from this Physostigma venosum plant, but it's working on activating this muscarinic, nicotinic, and these kind of somatic receptors. So really, we don't use this very frequently. It used to be part of the coma cocktail. Have you guys ever heard of a coma cocktail? Basically, it used to be if your patient showed up and they had decreased mentation, if they were very somnolent or just comatose, you give them this coma cocktail to try to wake them up. Does anyone know what might be in that cocktail? So oxygen would be one, right? Because if they're not breathing, that could be one reason why they're comatose, right? You give them sugar, so you give them dextrose in case they're hypoglycemic. You would end up giving them naloxone, which we'll talk about as being an antidote for. Do you guys know what naloxone is? Yeah, for opioids. So naloxone used to be in there, and then we also used to give physostigmine. Physostigmine used to be used to reverse a lot of different types of poisonings, probably inappropriately so. Really, this should only be used for anticholinergic poisoning.
Did they just give the thiamine before the sugar just in case?
They would oftentimes give thiamine as well, just for those kind of chronic alcoholics and worried about Wernicke's and stuff. Yeah. So thiamine was in there, but that wasn't really one of those things that was reversing any of the actual CNS effects. Yeah. But anywho, so we'll give this drug if they're having kind of refractory seizures, or they're having arrhythmias. We'll go ahead and use this drug potentially. You do want to be careful because as this is a cholinergic agent, if you're worried about things like if they have asthma or COPD, you could potentially cause an exacerbation. We do not use this for tricyclic antidepressants. Kind of another topic, but it's contraindicated for that. It can cause some arrhythmias. But if you give it too quickly, or you give too much of it, it can actually put them into a cholinergic crisis. So you kind of want to balance it out, make sure you don't give them too much. So a good example of an anticholinergic case and how difficult they can be to manage. We had a kid, I don't know if I told the story, but the kid that did the plates of triple C. You guys know what triple C is? I don't know who the drug kids are if they say. So it stands for Corsi and cough and cold. It's a very common cough and cold preparation you'll find out there. And again, the thing you'll find is with these teenagers is they have way too much time on their hands, and they can get access to these drugs very easily. They can buy a bunch over the counter. They may have it in the home already. And so there was this party that was going on. These kids were doing plates at a time. So basically like the big blister packs you'd pull out of the box. They would do say one plate, and that would get them fairly high. This kid had never done it before and said, "I'm going to do 2 plates." Bad idea for him. So he's probably like 17. Ends up being brought in to the peds ER and ends up taking, and if you guys think of like a normal dose of lorazepam for a seizure, what kind of dose do you think of? Does anyone know? Usually like 2 milligrams, right? 2 milligrams is enough to usually to stop most seizures in a lot of cases. This kid needed 14 milligrams just to calm him down enough to where he would at least fall asleep. Okay, 14 milligrams. This is a huge amount. That's like enough to put like an elephant out, right? So anyway, so you need this much because he's having so severe anticholinergic effects, and that would have been a case where if he developed seizures, we could have given the physostigmine in order to help reverse that, and that would have been kind of our next stop on that pathway. But because a lot of people have some hesitancy to give physostigmine, it doesn't get used until it's really like refractory cases. So anyway, don't do triple C's. It's not worth it, I would say. So you can see what happens if you give it too quickly. Basically, just more kind of overt cholinergic symptoms, bradycardia, seizures, hypersalivations. We want to avoid that, so we give it pretty slow. Next, you have your sympathomimetic drugs, and so certainly we covered some of these that will have these activities here. So a lot of them are going to have this mixed activity where you can see them activating both alpha and beta receptors, but it's important to kind of delineate between the two. So if you know that you have an exposure to one type of drug, you can expect or know what to expect to see based on the receptor pharmacology. So for instance, a lot of drugs have kind of mixed activity, things like PCP or phencyclidine, your monoamine oxidase inhibitors, cocaine, amphetamines. They're all going to be pretty much equally activating both alpha and beta receptors. Again, alpha receptors are primarily going to cause a lot of vasoconstriction, right? So hypertension, you're going to see beta-1 activity typically causes Yeah, mostly heart rate is what you're going to see. So a lot of tachycardia associated with it. You guys know what beta-2 receptors do? You activate those? Yeah, so you think about the lungs, so it causes smooth muscle relaxation, so you can actually see some vasodilation from that aspect. Certainly in the lungs, you can see some smooth muscle relaxation. Right, so looking at the pharmacology, you can kind of figure out what these different toxidromes might look like. So for instance, you know, if you had a beta agonist overdose, so say for instance you have, you certainly have drugs like albuterol, has a pretty short half-life. You wouldn't expect to see a lot of toxicity from that. You guys ever heard of clenbuterol? So if you ever get into like the bodybuilding culture, clenbuterol might be something you hear about. And basically it's thought to activate these beta-3 receptors and actually causes lipolysis. So it'll be used sometimes by weightlifters and bodybuilders and stuff in order to cause more fat loss. But again, it's going to be kind of non-specifically activating these beta receptors. And the other thing, clenbuterol you can actually make in the kitchen if you have the formulas online. I would not recommend doing that, but anyway, so you can do that, and basically there was a case reports of these two bodybuilders who ended up abusing clenbuterol. They come in, they were very tachycardic from the beta-1 effects. They're very hypotensive because of the beta-2 effects, and they also, do you guys remember that we used albuterol for hyperkalemia? Right, because you can cause inward shift of potassium. They also came with very low potassium levels. So again, because of that shift inward, I think their potassium's like 2, 2.5, something like that. So again, knowing the receptor pharmacology, you can guess what those kind of presentations are going to look like. Of course, if you have kind of a mixed agonist, it's all kind of out the window at that point. You're just going to kind of see overwhelming sympathomimetic effects. So a lot of the drugs are going to either work by directly activating the receptors, so things like phenylephrine, phenylpropanolamine, which used to be used in a lot of weight loss drugs, which you took off the market because it was causing strokes and things like that. Epinephrine, those are directly activating those receptors. You can have some drugs that actually increase the release of catecholamines centrally. So think about things like amphetamines and cocaine. They will actually cause the brain, the neurons to spit out more catecholamines. And then some of them will actually block the reuptake or affect the metabolism. So think about things like monoamine oxidase inhibitors, antidepressants. Those are keeping, basically blocking that reuptake of things like norepinephrine from being recycled in the CNS. So when you're looking specifically at the alpha effects, you'd expect to see things like mydriasis. You can see vasoconstriction or hypertension, diaphoresis, and then even platelet aggregation. So you do worry about things like cocaine chest pain. You always have to consider is it an actual MI that's happening there, because you do have these positive platelet effects causing them to potentially clot. With the beta-1 stimulation, you expect to see increased inotropy and chronotropy, so faster heart rate, heart beating stronger, and then the beta-2 effects are going to be seen more causing vasodilation, hypokalemia, smooth muscle relaxation. Again, just looking at the type of drug you're dealing with, if it was a pure alpha agonist, you would expect to see things like they're hypertensive, but they may have a normal or diminished heart rate, right? Because the heart, the SVR has gone up so much that your cardiac output needs to drop in order to maintain balance there. So you may see actual bradycardia associated with that. If you have just a beta-1 agonist, you could expect to see increased heart rate. Probably you're going to have some reduced blood pressure, right? Beta-2 effects, see a lot of tachycardia with hypotension, and then if you have a mixed agonist, things like theophylline even can cause this, they're going to cause all of the above. So you can see tachycardia, hypertension, hypotension potentially, so it just depends on kind of how they present and if there are other drugs that are involved here. So as we mentioned previously, there's a big differential diagnosis here. Other things that could be presenting with kind of sympathomimetic type of effects. So be wary about that and trying to rule things out. So for instance, how could you rule out serotonin toxicity? Yeah, so you can ask if they're taking antidepressants. For someone who is intentionally trying to harm themselves, how can you tell if they're lying? Their lips are moving. Yep. That is a handy rule of thumb. So either for intentional abuse, intentional harm, if their lips are moving, they're probably lying to you, right? So you're oftentimes going to get a good history from them, especially if they come in comatose, like they're not able to communicate with you if they're just so altered in their mental status. So that can be difficult. One of the things we'll do, we'll actually call pharmacies. If you go to fill a prescription, where are you most likely to fill it at? CVS, Walgreens, there's some big pharmacies you can call, right? And so most likely people have filled there. You can get some kind of history. You say, hey, I got this guy here. I just need to figure out. And oftentimes, if you say, like, hey, I'm calling from a hospital or whatever, they're pretty forthright with the information. You give give the name, date of birth, all that kind of good stuff. So you can figure that out. You guys remember that eForce program I talked about previously, where you can see where patients are filling opioids at? That could be a good sign to tell you specifically what pharmacies they fill at, which is nice. And again, all these pharmacies have interconnected records for the most part, so you can call one and be able to get records from other ones, which is nice. So that could be a big thing. And then just interviewing family members and whatnot, figure out what else is possibly in the house. So you can rule things out potentially by looking at what the possible sources of exposure are going to be. So anyway, one of the big things we run into though is that sympathomimetics and anticholinergics look very, very similar. So one of the ways we can tell the difference between the two is that one, with anticholinergics, are they typically dry or wet? Anticholinergics are typically very dry, right? So dry mouth, urinary retention, dry skin. So that's one way we can tell the difference between these two, is the fact that typically you're going to have dry mucous membranes and skin. And then also typically if you're listening for bowel sounds, anticholinergics are going to have diminished bowel sounds because they're slowing down the GI tract. Sympathomimetics should have normal to overactive bowel sounds, right? And then how do we treat those guys? Obviously, the ABCs are going to be the big thing. GI decontamination. This can actually be dependent on the type of exposure that a patient has. So obviously, you know, if you had someone who was snorting cocaine, how would I decontaminate the nose if it still had powder residue? You can use saline? Well, he's going to thank you for that. You just solubilize all that drug, and he's going to absorb it now. Good job. Just kidding. That's the same answer everyone always gives. Everyone always says saline. They say that. Actually, what we end up using is Vaseline or some kind of like oil-based product, or like a Q-tip. And that way you can just kind of wipe it up, and then it's all good, right? Everyone always says saline, so I like to use that joke. But think about things like that. Think about, you know, especially if you work down like Miami-Dade, what type of people coming into the country might you expect to see with a possible sympathomimetic exposure? Drug mules, yeah. Yeah, so you talk about body stuffers and body packers and things like that. So you have people who have potentially very large amounts of sympathomimetics like cocaine or amphetamines in their GI tract that's been very well wrapped, but you could have breakage of those things. So you have to consider how to get that out of the stomach or out of the GI tract. You know, sometimes we'll use whole bowel irrigation, where we use Miralax or Go Lightly. It will basically just flush out the entire GI tract to get rid of those. So lots of different routes there. Certainly charcoal could also be used if you're within the hour time frame. But best thing to do for these patients, put them in a nice, calm, cool environment. Sometimes they do require active cooling. So if I needed, you know, for especially some of these kind of designer kind of amphetamine type products like your Gravels and your Flacas and things like that, they get very, very hyperthermic. You can see temperatures 106, 107, no problem. What's kind of some active ways I can cool down these patients? Cooling blankets. Hey, cold fluids, right? So cold saline can be useful here. You can also use like ice packs in the axilla and the groin. That can be very useful as well. Sometimes we'll do evaporative cooling, where we'll kind of spritz down the patient with like a water bottle and put a fan on them, and that can help as well. So lots of different ways to cool them down, but that may be one of the most life-threatening things, because as you get very, very hot like that, you start to muscle breakdown, you get rhabdomyolysis, you get renal failure. It can all go downhill from there. So very, very important to make sure that you get their temperature under control. And then we use benzodiazepines to help with both the hypertension, the tachycardia, seizures. Benzos are our best friend when dealing with these sympathomimetics. So you can note that the treatment between the anticholinergics and the sympathomimetics is very, very similar. Give them lots of benzos, calm them down as best you can. The only difference is with anticholinergics, potentially you can use physostigmine as an antidote. Okay. Sometimes you have to use some short-acting cardiovascular agents. We may use beta blockers like esmolol, along with a vasodilator like nitroprusside, but we won't get too much into that. Mostly just stick with benzos and you should be fine. All right, next we have the opioid toxidrome. Opioids are derived from the papaver somniferum. So where you get things like heroin, your morphine, your codeine. Again, I would tell my heroin joke, but I've already told you that like twice now, so I'll avoid that one. But just be aware that not all opioids are created equally, right? So you have ones that are naturally occurring, which are like your heroin, your morphine. Those are very easy to reverse with our antidotal agent, which we'll talk about in a second. The newer ones are much more synthetic in nature, and they are a lot harder to reverse. So things like fentanyl, things like methadone, things like buprenorphine, these are things you're seeing more common use of, you know, because methadone used to only be used for what indication? Yeah, for detoxing, for patients who are opioid addicted, you'd use that as a way to kind of wean them off, right? Buprenorphine, the same thing. But nowadays, you're seeing more and more patients using methadone to treat chronic pain, right? Because it's a nice long-acting opioid. It's a valid indication for it. It's just that's what you're seeing more and more of. So just be aware that, you know, more of these patients are going to be potentially exposed to this stuff, and so that they can have you know, very different effects depending on you know, the receptor pharmacology and things like that. So again, we know that they are working primarily through the mu receptor. Again, that's where we're going to see a lot of the analgesia, the euphoria, meiosis, respiratory depression. This is the big thing we're going to be focusing on here. There's kappa and delta, but we're not going to be so. This is really not what people are abusing these drugs for. It's really for the mu effects. So many routes of exposure. Some people will try to break the extended release preparations of things like OxyContin in order to snort them or to inject them. Fentanyl patches can also be another consideration. So you know, you have a patient who comes in, they look like an opioid toxidrome, you give them Narcan, they wake up and they resedate. Well, perhaps they have a patch on that they're still absorbing drug through actively, right? So you have to consider, you know, dressing down your patient, look all over for patches and things like that to make sure they don't have continued exposures. So, and then looking at the time to effect, it can vary depending on how you get exposed to this. And this kind of applies to all drugs. But you know, out of IV, oral versus inhaled, which one do you think has the fastest onset of action? Inhaled, yeah, actually it's the fastest onset, right? Because the time to get from the bloodstream to the brain is the shortest, right? The distance is just the shortest. If I give it IV, it's also go through the venous system, go to the heart, then go to the lungs, and go back to the heart, and then go to the brain. Versus if it's in the lungs, it goes straight to the heart and then to the brain. So that's the fastest onset. Those are oftentimes also the most addictive substances, is when you get that high of a level that quickly, and then they drop down very precipitously. It tends to be more addicting for patients. But so just consider how long it might take. Oral obviously is going to be the slowest onset, so you can have delayed effects from that standpoint. And then just be aware that the duration of action can be pretty variable, right? So things like heroin, fairly short acting, whereas things like methadone can have a half-life of 15, 30 hours, no problem, right? So in some of these cases with these large overdoses, especially if they have slow GI tract and they're having delayed absorption, you may see effects for, say, 2 or 3 days, potentially. So the way the toxidrome looks is obviously from the CNS standpoint, they're going to have CNS depression. Again, they're going to be seeing this kind of euphoria, sedation, analgesia associated with it. As far as the eyes go, you may see meiosis. They talk about pinpoint pupils. You don't always see that, but if you do see it, it can be a good clue there. From the respiratory standpoint, you're going to see respiratory depression, and again, you may not just see a slowed respiratory rate, but they could just be kind of, you know, bradypneic. So you may need to actually be monitoring for things like end-tidal CO2 to make sure they're not kind of retaining more CO2 than they should. That can oftentimes be the first sign that you're looking for. They're retaining too much CO2, that they're not oxygenating appropriately. From the cardiovascular standpoint, you may see some relative bradycardia, maybe some hypotension, especially with things like morphine, if you have a lot of histamine release associated with that. And then you're expected to see decreased bowel motility, constipation, possibly some nausea and vomiting as well. And then maybe hypothermia. Usually it's going to be more for patients that are kind of been down for a prolonged period of time. They tend to get hypothermic more than anyone else. Okay. Sometimes you can find some opioids that do not act like others, and so you can have ones that can actually influence things like serotonin syndrome. So things like tramadol or things like meperidine can actually block reuptake of serotonin to some small degree, and so you may actually see that interact with their SSRIs or their TCAs, right? Some of them can cause seizures, so particularly tramadol can do this. Meperidine or Demerol can do this as well, and then we have propoxyphene. That one was actually taken off the market due to this toxicities. And then you guys remember that story I talked about the lady that overdosed on buprenorphine? Same thing applies to here, where you can actually induce withdrawal with buprenorphine by just how tightly that drug binds to the receptor. So if someone was, you know, abusing methadone or they're abusing their OxyContin for a long time, and then they were to have a partial agonist like this come along and displace the oxycodone, you can actually put that patient into withdrawal. Okay, so just be aware that sometimes they can have kind of odd presentations. You know, you don't always think seizures with an opioid, but it can occur with the right drug. Okay, and then drug screens. Drug screens are traditionally very bad. Hopefully, if you learn anything from these set of lectures, is that they really aren't worth a whole lot, clinically speaking. Everyone orders them all the time for drug ingestion, but very rarely does it ever actually change your therapy or change what you're doing with the patient. So oftentimes I just tell providers, just don't do it. You have to know what your drug tests are specifically testing for. Very frequently, if you just have like a standard urine drug screen, like the kind that you would do for like a job or something, they're only looking for usually THC, cocaine, amphetamines, like TCAs, THC they're looking for, PCP, which is like, who uses PCP anymore? No one. And then Opioids would be the other one. Yeah, so those are the big ones. The opioids, though, they really are only going to screen for things that look like opium or look like heroin. So it picks up those very easily. If I was using codeine or morphine, that would show up very easily. If I was using something like fentanyl that doesn't look anything like morphine, that doesn't pick it up, right? So you have to have actually specific screens in order to test for that. So for instance, like during my fellowship, we were at Shands UF up there in Jacksonville. The lab had some extra money, and they were like, well, what do you want us to test for? And we were like, well, we see a ton of oxycodone, let's test for that, because our screens were not routinely showing positive for that. So that was an additional benefit we had, that we can actually detect if that was in the system. So, so just keep that in mind, that you need to know what your drug tests are really testing for. There's lots of false positives, lots of false negatives, so very rarely is it ever clinically useful. And again, if you had a patient who was coming in and they were CNS depressed, they were respiratory depressed, they had myotic pupils, and they were negative on their urine drug screen for opioids, are you just going to say, well, it's not an opioid, I'm not going to give them Narcan? No, you're still going to treat them like an opioid until proven otherwise, right? That's going to be the big thing there. So just again, ABC is the most important aspect here. Make sure they're breathing appropriately. We can use GI decontamination like charcoal potentially. This is another one where you can maybe extend that out to 2 hours because you do have the slowed GI tract. And then naloxone is our go-to drug. Has anyone ever seen a Narcan reversal? All right, there's a YouTube clip. There's a movie called Bringing Out the Dead with like Nick Cage and Ving Rhames, I think, where there's like a heroin overdose, and they use Narcan to kind of hold this like religious ceremony around him. It's very, very funny if you watch that, but that's basically what it looks like. So I recommend you YouTube that later. But basically, it goes in, it's a competitive antagonist, and knocks all those opioids off the receptor, and they wake up just like that. So is that, the guys that seen that, is that your experience? They woke up pretty quick. Yeah, so usually like Exorcist in some cases, if you give too much, they wake up and they're vomiting everywhere. And so again, that's going to immediately throw patients into withdrawal if you give too much. And so very frequently, you have to be very kind of light with the dose if they are a patient who's known to be using opioids chronically, right? The ideal situation, you give them just enough to where they just kind of start yawning, showing that they're starting to get that response to their built up CO2 back. They're starting to breathe more. You don't need them to be awake. Most of the time, these patients are much better off if they're asleep. You don't want to actually deal with them anyway. But lots of different routes. You can give this IV, IM, you can give the ET tube, so lots of different routes that are available there. Very fast acting, but you have to remember it's very short acting as well. So usually within 30 minutes or so, the drug wears off. You may need to redose them if the patient ends up resedating. Okay. So again, usually for the more kind of naturally occurring opioids like heroin, like that's very, very responsive to naloxone and give very small doses. In some places where they are dealing with a lot of heroin addicts, they will use like micrograms of naloxone in order to reverse that. You start with like 4 micrograms that they're giving. Whereas down here where we see a lot more oxycodone, nowadays we're starting to see more heroin just because a lot of those pill mills were shut down. But we see more oxycodone, methadone, we have to use larger doses. They don't tend to be as responsive. So sometimes up to like 10 milligrams we'll give in order to help reverse that. Sometimes you have to put them on a drip afterwards as well, just due to them resedating. You put them on a Narcan drip, and again, they just want them to be arousable to voice. Again, they don't have to be actively awake. All right, then one of the last toxidromes we'll talk about is the sedative hypnotic. This is again another very kind of wide-ranging category. Lots of different drugs fall into this. So all of your barbiturates fall into this. All of your benzodiazepines fall into this. Muscle relaxants. So a lot of things like Flexeril or cyclobenzaprine, tizanidine or Xanaflex, all those fall into that category. And then also just some miscellaneous agents, ethanol, probably one of the most common co-ingestions that you run into with these intentional exposures, right? People get very depressed, they drink, and then they overdose on whatever drug they want in order to harm themselves. So ethanol is a very, very ubiquitous kind of substance in a lot of these cases. But you also have things like chlorohydrate. You guys ever heard of chlorohydrate before? It's a pretty old school sedative agent. It's where the term slipping someone a Mickey is. If you've seen the Seinfeld episode, that's where that originally comes from, is chlorohydrate. And then GHB. You guys ever heard of GHB? Yeah, the date rape drug is where that one got a lot of its infamy, unfortunately, but it's gamma hydroxybutyrate would be that one. So again, they all kind of fall in this kind of general category of sedative hypnotic. Again, most of these are going to be working specifically by increasing activity of GABA, so opening up those GABA channels, increasing chloride influx, causing basically just kind of global CNS depression. So you can expect to see decreased mentation, nystagmus, ataxia associated with this. You don't typically see a lot of respiratory depression with these agents by themselves necessarily, but when you start to combine things where you run into problems. So if you take your Xanax plus your alcohol, more likely to see respiratory depression, right? Usually benzos by themselves are very, very safe. It's very difficult to overdose and die on just benzos alone, but it's when they have combination drugs where it become more of a problem. May see some slight hypotension with things like barbiturates, maybe some diminished GI motility, but not nearly as bad as like the anticholinergics or opioids. But just keep in mind that some of these are going to have kind of mixed receptor activity. So things like Flexeril or things like carisoprodol or Soma actually have some anticholinergic properties. So you may have kind of some mixed picture showing up when you have these kind of overdoses presenting to the ER. Again, mostly supportive care is the best thing for these patients, so just going to get their airway under control. For any kind of hypotension, we use fluids and then vasopressors, so usually norepinephrine is the one we like to go with most of the time. And then as far as antidotes go, you have flumazenil, which is used for benzodiazepines only. Okay, be very careful with flumazenil. It does not get used very often clinically because what's the biggest risk from giving too much flumazenil to someone who's on benzodiazepines chronically? Right, you worry about withdrawal, right? And so we mentioned that for opioids, withdrawal from that, is that ever fatal? Almost never. Yeah, they're going to wish they were dead, but they're not going to die, right? Overdose or withdrawal from benzodiazepines absolutely can be potentially deadly. A lot of seizures you see with that, and so sometimes you'll have patients who will overdose on a drug that causes a lot of seizures and also overdose on a benzodiazepine. They're helping you out at that point, right? They may be actually covering up a seizure with those benzos, and so we don't want to reverse that effect. So very, very infrequently do we ever give flumazenil. This is better for, if you're dealing with a patient who's in-house and you sedated them for a procedure with a benzo and you want to wake them up a little bit faster, or you gave them too much, they oversedate. This is the best place to use romazicon. And then sometimes to enhance elimination, we can actually do things like multi-dose charcoal. For phenobarbital, we're actually give them multiple doses, say every 6 hours or so, to kind of perform like a gut dialysis and to get those levels down more quickly. Sometimes we'll actually use urinary alkalization with sodium bicarb to increase the elimination there as well. And then obviously withdrawal can kind of mimic the more sympathomimetic kind of toxidrome. Just beware those kind of differences between the opioid and the benzodiazepine type sedative withdrawal, right? So withdrawal from ethanol, very similar to withdrawal from benzodiazepines, because again, you're having too much glutamate activity, not enough GABA activity. Seizures are definitely possible that we end up seeing with that. Okay, so I'll give you guys a 10-minute break now. We'll come back and continue on with more tox. Just a little bit about patient assessment. These are some things you may see when you have a toxic exposure, and it's good to remember what are the things that could cause this kind of picture, right? If you look at a patient who's got bradycardia, like what are some potential drug-induced causes for bradycardia? And this is where it pays to remember your pharmacology lectures and go back to their mechanisms of action, right? So things like beta blockers, right? So obviously beta blockers can cause bradycardia, but you have things like your cholinergics. Think about drugs like clonidine, right? Because clonidine is working how? Central alpha 2 agonist, right? So that is a sympatholytic, so it's decreasing catecholamine outflow, so that could cause bradycardia. Think about your non-dihydropyridine calcium channel blockers like verapamil, diltiazem, right? Those are all good ones. Even drugs like digoxin cause bradycardia, another bradyarrhythmias, okay? On the flip side, you have tachycardia. So really anything causing vasodilation or hypotension can certainly cause tachycardia as kind of a reflex mechanism. So that's where you can see things like your dihydropyridine calcium channel blockers. So sometimes you'll see hypotension, tachycardia with those, but certainly other anticholinergics, sympathomimetics. Iron can do this as well. Iron typically causes very severe hypotension with reflex tachycardia, salicylates, so keep in mind that lots of different things can be causing tachycardia, in addition to all the medical reasons, but you can certainly have lots of drug-induced causes as well. Again, the hypotension, we see this very frequently with both types of calcium channel blockers, clonidine. Think about like your TCAs. A lot of them have alpha blocking capabilities, so they can end up causing vasodilation from that mechanism. Again, you see things like iron, salicylates, digoxin all can cause hypotension. And then typically your hypertension is going to be more from sympathomimetic-based agents. It's the most common causes, but even things like thyroid supplements, right? You guys remember, how long does it take for your thyroid supplements like Synthroid to kick in? about a week or so, right? Because again, you have to convert that T4 over to T3. So sometimes you end up seeing issues with that if you have too much thyroid supplementation. Nicotine can be a big cause for this as well. Caffeine can do this again. Certainly we've seen enough overdoses of things like energy drinks and things like that. No dose, like more concentrated tablets and whatnot, certainly cause some pretty significant hypertension. There's a good website called Death by Caffeine. You can Google and basically put in your weight and you put in your favorite, your caffeine du jour, and it'll tell you how much you need to drink or eat in order to die from that. So a very interesting website. It's way more than you might actually think. You have to drink like a ton of Red Bull or coffee or something. Way more than you'd actually ever be able to consume at one time. But it's interesting to see that. So something that causes hypothermia. So if you have a patient come in hypothermic, this is more frequently due to patients who are like down for a prolonged period of time. So you can see things like carbon monoxide poisoning. You guys know where you most commonly see carbon monoxide poisoning here in Florida? Possibly in the garage from a car running. Hurricanes, yeah, the generator's running, because again, you don't want your generator being stolen, so you run the generator in the garage, and then you end up getting a lot of carbon monoxide coming in that way. We had one interesting case where a guy was actually cooking. He had 3 young children in the home, and he's trying to keep an eye on them in the house, and he was trying to grill, so he backed the grill up into the doorway of the house and was grilling up his hamburgers and stuff there. Of course, prevailing wind brought all the carbon monoxide right in the house, and then they all got toxic, right? But certainly opioids can do this. Hypoglycemics, some of your diabetic drugs, insulin, sulfonylureas can do that, and then sedative hypnotics as well. Hyperthermia is going to be more of a problem with a lot of your sympathomimetics. As I mentioned, some of those more designer, newer amphetamine type products like your bath salts and things like that cause very significant hyperthermia in a lot of cases. Salicylates, you can see this, phenothiazines like some of your antipsychotics, a lot of different things cause hyperthermia, mostly from an anticholinergic or sympathomimetic mechanism. Again, things causing bradypnea. Clonidine, opioids, sedative hypnotics most commonly, and then tachypnea. You most frequently see this with things like salicylates. That can be one of the first things that kind of clues us into a salicylate poisoning. If you see someone who's very diaphoretic and they're tachypnic, and you're like, what's going on here? And they have this history of taking BC powders for a toothache or something like that. It's a very frequent cause for salicylate poisoning. Cyanide can do this as well. Because listen to S-Town. It'll come up. But anyway, so cyanide poisoning can do this, and then there's also some irritant gases. So if you're inhaling something like, if you're cleaning your house and you accidentally mix like bleach and ammonia together, right, instead of getting some gas generation there, you can end up having tachypnea associated with that, right?
Yeah.
What was awful? Oh yeah, don't say too much though. I go listen to that. It's very interesting. It was like going back home, honestly, listen to the first few episodes. Like, oh yeah, I've heard of all these people. Anyway, meiosis, very frequently you're going to see this with cholinergic drugs. Clonidine, you can see this. Opioids. Again, clonidine looks very similar to an opioid toxidrome. Did I mention the case with a kid in with the clonidine patch? Yeah, end up swallowing the patch, and yeah, so again, patch ingestion is always kind of a problem because it's a big delayed release kind of a dosage form. But again, clonidine looks very similar, so if you see that, like, okay, let's try Narcan, let's try to reverse this kid, and end up working out very well for him. Mydriasis, more frequently seen with sympathomimetics, anticholinergics, a lot of antidepressants that are blocking reuptake of things like serotonin or norepinephrine. You can definitely see that as well. So again, we're kind of taking all these bits and pieces of the patient's presentation and try to clue us into what potentially is causing their issues. Again, looking at diaphoresis, so things are making them sweat, sympathomimetics, organophosphates, salicylates can do this. If they are having dry mucous membranes, you should be thinking anticholinergics. Very flushed skin, you can think about things like anticholinergics. Carbon monoxide can also do this. Cyanide can do this. You guys ever heard of boric acid ingestions? Or where you might have boric acid exposures? It's an old school cleaning substance called borax. It's basically it's a very good cleaning substance. They'd have cases where people were like cleaning out baby bottles with this borax, and they wouldn't clean it out appropriately, and so they'd have the kid actually ingesting some, and so they get this kind of boiled lobster-like appearance. So if you ever hear me talk about lobster babies, it's probably going to be a boric acid reference there. And then also sometimes you can have patients who are down for a prolonged period of time can develop these bullae. So especially like barbiturates, carbon monoxide, you're more likely to see that. Okay, as far as seizure-inducing agents go, we have a nice mnemonic here. So this is Otis Campbell. I'm not going to ask you to memorize this whole list for the testing purposes. I'll more kind of reference back to the toxidromes for that sort of thing. So I'm saying like, patient presented tachycardic, hypertensive, had a seizure, what do you think it could be? And, kind of go through the toxidromes. But just for your reference, there's lots of things that can cause drug-induced seizures, right? So organophosphates, TCAs, isoniazid. Do you guys remember where we saw isoniazid from? You have TB, right? So if you ever have like, a homeless guy who had a history of TB, think isoniazid if he's having seizures. Insulin, just due to the hypoglycemia, sympathomatics, obviously. And then camphor, do you know where you might see camphor at? Used to be used in mothballs very frequently. So if you have that mothball smell, that's what you're smelling is camphor. There used to be cases of camphorated oil that was being sold over the market, and that would actually end up getting mixed up with things like castor oil that they would give as kind of like a home remedy for constipation. And so they have kids developing very severe seizures due to this camphor. You'll still find this in a lot of like muscle creams and rubs and things like that. So ingestions from that in kids can still be very problematic. Aspirin, your amphetamines, your methylxanthines. You guys remember what methylxanthines are? Theophylline, caffeine, yeah, those are two big ones. PCP, benzo withdrawal, ethanol withdrawal can both cause seizures. Lithium is another big one. So again, especially with patients with a history of bipolar depression, like this is a big thing. All we worry about is them, going off their meds or taking too much. Whatever happens to be lidocaine as well. So lots of drugs that can cause this, but Otis Campbell is kind of the way we remember our differential. Certain odors may actually give away different types of toxicity. So again, this does not come up super frequently. Unfortunately, to say, I hate to cast a wide net, but a lot of our patients who are intentionally trying to harm themselves, maybe not the best hygiene out there. So smells are a little bit tough to pick out sometimes. But if you ever have bitter almond smells, think cyanide, right? You have things like garlic can smell like arsenic, which is why, if you wanted to kill somebody like your husband or something, you can put arsenic in their spaghetti sauce, and then they wouldn't even be able to detect it, right? Not that you should ever do that. But if you have someone like who ingested oil of wintergreen or something like that, you're thinking methyl salicylate, right? So it could be a salicylate type poisoning. And then rotten eggs is definitely a smell for sulfur, right? So anytime you hear smell rotten eggs, it could be something like hydrogen sulfide. There's actually some really kind of odd cases. This is actually happening in Japan, where they have basically these like they use a lot of like sulfur baths and things like that, but basically they had these tablets of sulfur that would mix with hydrochloric acid and ended up generating this hydrogen sulfide. And so they'd enclose themselves in like in a car. They would tape it off very well. They put up the signs that says like dangerous hydrogen sulfide will kill you, because basically the stuff causes like rapid knockdown like that. It's very, very fatal very quickly. This is kind of one interesting case where they were a new method for people that were killing themselves in a pretty kind of unique way from that standpoint. And then this is always a good thing to keep in mind, especially if you're out there in clinical practice. If you have a wide anti-gap acidosis, think about your mud piles, right? So we also include the cat mud piles. These are things that are easy to rule out in a lot of cases. They help to narrow your differential down to see like, why is my patient acidotic? So you're thinking things like methanol, where do you find methanol at? Probably don't use a ton of it down here in Florida because we don't get a lot of freezes, but you see it in windshield washer fluid, right? It's a very common one. Obviously, uremia you can rule out just by looking at the BMP. DKA, be another one. Paraldehyde, which we just keep in there because it keeps the mnemonic working, but I don't know where you find paraldehyde actually. Things like isoniazid or iron can cause this as well. Lactic acidosis, ethylene glycol, where do you find that? Yeah, radiator fluid, so we find that in antifreeze. Salicylates will do this. And then you have your cyanides, carbon monoxide, alcoholic ketoacidosis, which will sometimes happen with your chronic alcoholics. And then finally, toluene. You find this in a lot of paint strippers and things like that. So we have some guys that will try to abuse toluene by huffing it. We had one guy that was, he'd go to every Walmart he could find and just sit there in the back of the hardware section and just huff this stuff until police escorted him out. Very interesting guy. Certain agents will be radio-opaque, so sometimes you can actually use x-rays in order to help determine if a patient has been exposed to something. So we use CHIPES as our mnemonic for this one. So things like chlorohydrate. Heavy metals is probably the most common one you're going to see this actually be positive for. So someone had like, if they were ingesting, say, lead flakes, lead paint chips, things like that. Bullets, certainly you can see lead exposure from that. Different heavy metals can show up. Iron, obviously, so if you have iron tablets, those potentially can show up on the x-ray. Phenothiazines, some antipsychotics will, and then extended release products can do that as well. And then finally, metal salts, so things like potassium may show up. Again, if this is negative, so if like a patient came in and said, hey, I just ingested a whole bunch of iron tablets and the x-ray is negative, that's not good enough to say like, nope, you didn't actually do that, I'm going to send you on your way, right? But cases where people have missed things on the x-ray and they end up sending patients home prematurely and they come back very, very sick. So just be aware that if it's positive, that's great, nice to see it, but if not, then you can't rule anything out at that point. Okay, so quickly we'll go over decontamination. So different types of decontamination you'll do for these poison patients. We'll talk about dermal, ocular, and then gastrointestinal. So there's lots of different ways we can do GI decontamination for these patients. So first off, dermal decontamination, really, really important. And you guys know like what situation we might need to perform dermal decontamination like this? Yeah, terrorism attacks, like the sarin attacks over in Syria. Organophosphates could be a good one, yeah, absolutely. So especially if you had, because you worry about dermal absorption. We actually just had in Orlando, we do mass casualty drills every single year, usually in into March. And so this year when they did it, it was going to be, I think the scenario was there's a radioactive cobalt explosion in some of the in the courthouses. That was the scenario, and so you had to worry about radiation contamination on these patients, right? So that was the reason why I had to decontaminate. So you'll see those practices that happen usually once a year. Anyway, biggest thing to do is make sure you don't expose the healthcare workers, right? So one of the things I'll actually do for those patients when they're doing the drills is they'll make marks on them at various places, and so if they don't get actively decontaminated or they don't get appropriately decontaminated, they make it into the hospital and they still have marks on them, they'll say, oh, well, you failed that one, right? Now everyone in the ER is exposed to that stuff, right? So that's one of the big things they test for when they're doing these kind of drills. You have to make sure you remove all contaminated clothing. Anything still in the clothing could still be a source of exposure, so it's really important to undress these patients. And then we are typically flooding them with lots of water, potentially with soap or not. That's going to be more useful for more kind of oil-based substances. And then sometimes diluted bleach solutions as well can be used to help get rid of some of these products. Also pay attention to your larger patients who have like skin folds and things, because there's cases where you can have products still sitting there, especially like corrosive agents, and they can just sit there and just kind of keep burning away if you don't get in there and get all the folds cleaned up. Next, ocular decontamination is really important to make sure we flush out the eyes when you have these exposures, because time is tissue, right? So the longer something sits in there, the more of a problem we're going to have. Always remove contact lenses, right? Because anything that gets stuck behind the contact lens can continue to cause irritation. And we end up using sometimes what we call a Morgan's lens. You guys ever seen one of these before? These look terrifying to me. But basically what we'll do is we'll use an anesthetic to numb up the eye and then place this nice little contact lens looking thing with a tube coming off of it in there, and then you'll attach that to a bag of saline and just kind of run that through to flush out the eyes appropriately. Most of the time, if we're having a call from the parent at home said, hey, kid was playing with something, got it in the eye, we'll have them just kind of flush it out with tap water for at least 15 minutes, then potentially have them come in, if it was a corrosive type agent, bring them in for evaluation, just look for corneal abrasions and things like that. We had one patient, I probably told this story previously, but two young boys, they were playing with an empty bottle of Drano, tossing it back and forth, playing catch, because that's what they had at the time. And so cap came off of it, and you guys know what is in Drano? Yeah, a lot of bases. So sodium hydroxide probably being one of the biggest ones. So sodium hydroxide got in the kid's eye. So of course the kid's screaming, having a lot of pain. They bring him into the ER, and there we were trying to get a Morgan's lens into him so we could actually flush out the thing, but he was just fighting us so hard because he's in a lot of pain. He's freaked out. We ended up having to give him ketamine to like knock him out, do our thing, flush him out, and then wake him up, and then he was fine at that point. So just be aware there may be some different clinical situations depending on who your patient you're dealing with is. The big thing to note here is you're also testing the pH. You want to make sure you get back to a normal pH of around 7.2. So we can just use pH paper, just kind of stick it down in the conjunctiva and see where they're at. You also want to make sure you check that at least twice, because sometimes you'll get done flushing them, look like they're a normal pH, and then you'll come back 15 minutes later and they've kind of gone more acidic or more basic if there's still some substance around. Okay. Other ways you can do this, if you have a nasal cannula, you can actually hook that up to a bag of saline and put that over the bridge of the nose and then get good flow that way as well. So you can just kind of make sure you're kind of having that flow go out. And then Ipecac was our first GI decontamination. I can't tell you how excited I was to see that the GIF actually animated in PowerPoint. So, you guys have ever seen the Family Guy episode? It's very similar to what Ipecac did. Basically, it was a substance that directly activated that chemoreceptor trigger zone to cause very violent and severe emesis for these patients. The idea was if you had a toxin in you, you puke it back out and you wouldn't absorb it. Okay. The problem was we didn't get a ton of good return on our investment, and even when they did studies, they would have someone ingest a product and they'd have them directly vomit afterwards. You only got maybe 30% back. So certainly that can make a difference between life-threatening to maybe not so life-threatening, but it really is not going to be all that useful because we worry about the aspiration risk. It's just too many problems. But the other big reason why that you don't find Ipecac in use clinically anymore is because this would be abused by bulimic patients as a means to lose weight. And so it actually there's a cardiotoxin that's included in Ipecac. It's kind of something we didn't know about at the time, but basically you'd have these like young, especially young, very thin females who are coming presenting with these very large hearts. So they had these cardiomyopathies that basically they gave themselves CHF for the rest of their lives. So American Academy of Pediatrics came in and said, hey, we don't want you to use this anymore, and so it's basically removed from the market. You'll still see it used in some homeopathic preparations, but nothing concentrated enough to cause what you're seeing there. So who wants some chowder? Right. The next thing you may see used occasionally is going to be gastric lavage. Basically, this can be used for life-threatening ingestions within 1 hour. So it's kind of, again, the time frame for most ingestions is within 1 hour you want to get this done. This is very labor-intensive, basically putting down a very large NG tube or potentially an OG tube into the patient. You place them into the left lateral decubitus position. You guys know why you put them in that position? Yeah, so it burns, exiting contents from the stomach, hopefully. But basically, put them in that, you will instill either tap water, or if you're dealing with like peds patients, you'll do saline. Basically, instill it in, and then suck back out whatever comes back out. Okay. The problems with this is that, for one, you have these tiny holes that are drilled into the side of the tube. If the toxin or whatever happens to be the tablet cannot fit through the tube, it's not going to do you any good, right? So very infrequent is this ever that useful. And again, it's so labor intensive, most people do not have practice with it. They're going to be beyond that hour anyway. So we don't do this one very commonly. Again, the big contraindications for doing gastric lavage include they have an aspiration risk, including if they have either a corrosive agent or a hydrocarbon, because again, if things are burning on the way down, they're going to burn on the way back up, and we worry about aspiration to the airway. Foreign body ingestion is very similar for the aspiration risk, and then if the toxin's bigger than the tube holes, then it's not going to work. And then complications, obviously, going to be the perforation, potentially if you have a corrosive agent, and then the possible aspiration. So again, not used super commonly. However, we do use a lot of activated charcoal. Again, this is going to be within 1 hour of the ingestion, potentially 2 if you're dealing with an anticholinergic or an opioid and they have diminished absent bowel sounds. That is sometimes when we use charcoal. Basically, has a very large surface area. It's been kind of charcoal. Basically, has been crushed, high pressure and heat, and it has a very high surface area that can bind up a lot of toxins. Typically, the dose we end up giving is anywhere between 25 and 50 grams, and usually it's 1 gram per kilo in peds that we'll administer to them. Do you guys know what this tastes like? If you had to guess. It's actually, yeah, so the texture is definitely gritty. So it definitely has a very gritty texture, but it tastes very sweet, actually. It's in a sorbitol base that it's not that unpalatable. But again, if that gritty texture is usually what gets people. So again, usually we'll give this in a covered container with a straw, maybe with like some chocolate milk or something. That way it makes it a little bit more palatable for them and they can get that down. Yes, ma'am. You do not use a whole lot. A lot of it is just you kind of let it pass. Yeah, because a lot of times, like the things are going to naturally kind of neutralize themselves, right? But the problem is you're really the biggest thing with those agents is that it's a lot of follow-up GI management, right? Because again, you worry about having strictures form, you worry about perforations and things like that. There's really not a whole lot we can do for those, unfortunately. There's some thought that you can give like steroids that may help with the healing, but it really doesn't borne out to be very, very effective. But yeah, those can be pretty bad ingestions. Sometimes you have to have bowel resections being done and things like that for more severe, like especially alkali ingestions.
What's the most common form, like batteries, or how?
No, batteries are an interesting topic, but usually it's going to be things like drain cleaners and whatnot. So if you have like an intentional ingestion of a drain cleaner, large bleach ingestions, like concentrated bleach, could potentially be corrosive. High concentrations like hydrogen peroxide can also be problematic. We had one case where a young girl, basically there's a health food store, usually hydrogen peroxide is like 3% concentration. There's a health food store that had like 98% hydrogen peroxide, very, very concentrated stuff. This little girl ingested that, causing pretty severe burns down the esophagus. The other big thing with hydrogen peroxide is it generates, when it breaks down, what does it turn into?
Gas.
Yeah, water and air, right? So it turns into O2. So that air, when it generates those bubbles and whatnot, can actually cause air emboli that can form, that can actually partition over into in the aorta, can cause issues there. So you can see stroke, you can see all kinds of pulmonary embolus that can happen from that. So that can be very problematic. So yeah, so basically this kind of corrosives basically just let the gut rest for the most part. Sometimes we'll put patients on total parenteral nutrition, so that way they're not having to eat anything or take anything by mouth. But yeah, it's a lot of supportive care for those guys. Because again, you don't want to neutralize it, because then what would happen? Generate heat and gas. You don't want, that's just going to cause further damage. So if you had someone ingested hydrochloric acid, you don't give them drain cleaner to counteract that. It just causes more problems. Because you worry about perforating the esophagus. Yeah, that's really the big thing, is you really don't want to stick anything down there if you don't have to. Eventually, like once the tissue starts to heal some, you can do like an EGD to go and see kind of what the extent of the damage is. But and it depends on the strength of the acid and all of that, or the base, and how bad it's burning through. And again, if you had to consider which one burns worse, acids or bases, which one would you think? Yeah, bases actually burn a lot worse. So acids normally kind of burn themselves out. They cause this coagulative necrosis, where they actually form an eschar. But with the bases, though, they cause this we call saponification, where it keeps kind of just continually burning down, kind of working through those lipid bilayers and whatnot. So those actually burn way worse in general. So that's why we worry more about drain cleaners and things like that. So anywho, so charcoal is really important to know what you cannot use it for, and so it does not bind to things like alcohols, will not bind to heavy metals, iron included with that, lithium included with that, and then hydrocarbons as well. Hydrocarbons, we're thinking about things like gasoline, we're thinking about things like turpentine, different products like that. Do you guys know where the most common gasoline exposure we see at the poison centers is? Yeah, siphoning gas is usually the biggest one. So either they're doing it like for, their lawnmower at home, or they're trying to steal gas or something like that. I've had a few people actually owned up to it, like, yeah, I was trying to steal gas, and ended up getting a big mouthful of it. And okay, well, can't tell you it serves you right, but sometimes Darwin, had a thing. I think he had a good idea. Anywho, right, so hydrocarbons not going to be no good, doesn't bind to it, and then again the aspiration risk is potentially worse than anything else. So other contraindications if they're an aspiration risk, so very frequently we cannot give charcoal to these patients if they are CNS depressed enough to where they're not really protecting their own airway. Obviously if they're intubated, you're kind of protecting the airway for them, and then we could potentially give it. But that would be one contraindication. If they have intestinal obstructions or any kind of corrosive ingestion, being other indications, do not give charcoal. So this is probably one of the most frequent questions you get is, hey, can I give charcoal? First thing I ask is, when was the ingestion? If they say, I don't know, don't give it, because chances are it's probably after the hour. If they say it's within the hour, then you have to find out what specifically they ingested. And if it's foreign body, corrosive agent, hydrocarbon, metal, say, nope, don't do it. Okay, those other things that we can bind to. Then we have whole bowel irrigation. This is basically flushing out the entire GI tract with polyethylene glycol, or Go Lightly. This is going to be good for things like heavy metals. This is good for body packers and stuffers. I kind of alluded to this. Do you guys know what the difference is between a body packer and a body stuffer? Bless you. So body packers, think about packers are going on a trip, they are going somewhere. Usually they are the drug mules and things like that, so they are very well packaged. Usually like a little kind of wax dipped kind of containers or condoms or things like that. Very well packaged, typically a very large amount, right? Because they're moving a large amount of drugs, across borders and things like that. Body stuffers, on the other hand, are people that see the red and blue lights and they take whatever they got and they say, I got to get rid of this, and swallow it, right? So typically smaller amounts of drugs being ingested, but they're not as well wrapped, right? So typically you're more likely to see those kind of come open and have absorption. But for those type of ingestions, we can use Go Lightly to flush out the whole GI tract and clear that out. We can also sometimes use this for sustained release preparations, sometimes for concretions that form. Certain drugs can actually form kind of large balls of drug that are sources for delayed absorption. So aspirin does this. Sometimes iron will do this. Certainly you can see other kind of bezoars that can form. You guys know the term bezor, right? What types of bezors can you have? You have hair, which you call what? Yeah, trichobezor, but we call these pharmacobezors essentially. So there's different varieties that are out there. I think a phytobezor if it's like a plant matter, something like that. So there's lots of different varieties. But so sometimes we'll do it for that. And basically we're starting out for an adult patient, we'd put an NG tube down, because some people say they'll drink it, but you guys know what Go Lightly tastes like? It's like warm sweat. Someone just described it to me. Right, because it's got electrolytes in it, right? Because it doesn't cause a lot of electrolyte shifts. So that's how it was described to me. I said, well, I wouldn't want to drink that either, I think. So typically you put an NG tube down, hopefully give them some antiemetics, and you start at, say, 500 mLs an hour, and then you gradually increase up to about 2 liters an hour. And the goal here, the end point, is we'd like to have clear rectal effluent. So again, 3 words that I never thought I'd say so much in my life, but that is the goal, right? You just want to make sure that everything's cleared out. And sometimes what we'll do, especially if we have like a body packer or stuffer, and we're worried about the drugs being absorbed, we'll actually give, I call this go darkly, where you give a dose of charcoal beforehand and then flush it through with the go lightly. So that way if anything does break open, you can bind it up with the charcoal, and then also you can tell like when stuff's starting to come through, because once they start pooping black, then you know, okay, it's the charcoal coming through. So again, you have to be really careful with this one, especially with the aspiration risk, because go lightly in the lungs. It's going to be a recipe for pneumonitis. You don't want that. Okay, so any questions on GI decontamination? So again, if I gave you a case on the test and said, hey, this patient, PEDS patient presented 2 hours after an ingestion of a whole bottle of Tylenol, they're asking, can we do charcoal? You say no, right? Or I might ask you, which types of GI decontamination can you do, and you'd say, oh, none at all, right? Okay, so next we're going to talk about some specific types of toxins. These are some things you're going to run into somewhat commonly, and acetaminophen is going to be one of the big ones that you run into. And why do you think acetaminophen is so common? It's ubiquitous. It's available everywhere. And then the other big thing is that it's in a lot of combination products, right? So what type of drugs do we commonly see acetaminophen formulated with? Percocet, oxycodone, cold medicines, diphenhydramine, so Tylenol PM is a very common one. So it's very easy to get too much Tylenol and not really realize it in some of these patients. But again, very common one to overdose on intentionally, and also it's relatively cheap, relatively easy to find, so this is why it's so common. So basically, there's a couple of different ways that acetaminophen gets broken down, and the reason why it becomes toxic is we kind of overload the body's natural means of detoxification. So, for instance, normally when you have acetaminophen being broken down, some of it will go through the kidneys unchanged. That's fine. Some of it will go undergo this glucuronide conjugation, where we add a glucuronide molecule onto that, becomes more water soluble and get rid of it. That's fine too. And then there's also a sulfate pathway. These are the normal ways your body is able to detoxify Tylenol and get ready for renal elimination. Okay. What happens though when you have too much Tylenol on board, you kind of overwhelm these natural pathways, and then more of it's going to go down to this pathway where it gets metabolized by the CYP450 2E1. 2E1 is also notable for metabolizing alcohol as well. So this can be, we'll talk about interaction between alcoholics and Tylenol. But basically it undergoes this 2E1 pathway, and it produces this product called NAPQI, N-A-P-Q-I. NAPQI itself is the toxic component here. This is what's causing liver damage. This is what's causing all the other problems you see with Tylenol. This is why when you get too much Tylenol, you exhaust those natural pathways and you generate this NAPQI. Your body can glutathione conjugate some amount of NAPQI on its own, so you have some built-in tolerance to this. But again, once this gets overwhelmed as well, this is when you're going to get the toxicity. Okay, this is where we're going to need an antidote in order to help detoxify this, and we'll look at that in just a moment. So again, you typically see toxicity develop once your glutathione stores drop by about 30% or so. And if you're looking at what a normal therapeutic dose for Tylenol would be, it's anywhere between 10 and 15 mg per kilogram, right? A toxic dose for these patients are going to be when they're getting around 150 to 200 milligrams per kilogram. So once they start getting in that range, then we're starting to think, hey, they probably have enough to be potentially hepatotoxic. Okay. Once this NAPQI starts to form, primarily in the liver at first, it's going to start to cause cellular damage, starts to generate reactive oxygen species, causing issues there, causes cell death essentially. This is where you're going to see some of your LFTs start to form, things like that, and then that NAPQI is not just going to stay in the liver, it's going to affect other cells as well. So this is where you can see kidney damage, heart damage, all sorts of different problems from this, especially with more progressive type toxicity. It's important to note though that this takes time to occur, because again you have to overwhelm your natural kind of detoxification pathways. So do you guys know when you typically see acetaminophen toxicity start to develop? Usually 24 to 36 hours afterwards, right? So this is the other big problem you run into with Tylenol. So if someone overdoses on a bunch of Percocet, right, they come in, when do you expect them to start to develop the opioid issues? within an hour or so, right? They should be starting to get pretty CNS depressed, respiratory depressed. They may be more toxic from that, and you can treat that pretty much initially. But that acetaminophen is never going to have its own toxidrome, right? Because it's so benign early on. It's not until 24, 36 hours later you realize, oh, this person's having fulminant hepatic damage being done here. So this is why we always, when you're checking labs on an intentional overdose, you check Tylenol level, right? So any intentional ingestion you have, you always got to check a Tylenol level because it is so ubiquitous, because it does not have a toxidrome associated with it, and by the time you find that there is damage being done, you're kind of behind the 8 ball already, okay? So some things that will predispose patients to toxicity is that they're having increased frequency of dosing. So for instance, that they are self-treating their own pain, and they're kind of taking more than they should consistently, that can increase their risk. Just prolonged use of excessive doses. That's why when you are educating patients on how much to take, you tell them how much to take in a 24-hour period. Yeah, no more than 4 grams, right? That's always the recommendation. They've actually backed that down for the over-the-counter products because these patients who would take 4 grams every single day, even they were starting to develop some toxicity, especially if they had any concomitant liver problems. So now they say like 3250 is like the recommendation for over-the-counter use. Chronic alcoholics who typically have upregulated CYP2E1, they have more of that product going through that, more Tylenol going through 2E1, making more NAPKI, so they're more predisposed to toxicity. And then people have decreased glutathione concentrations, usually chronic alcoholics and other people with hepatic damage. Basically, you can stage out acetaminophen toxicity into several stages. The first one is going to be this kind of hour 0 to 24-hour period. You're going to see no hepatic injury. They're most likely to be asymptomatic. If they have anything, maybe some nausea, vomiting, but for the most part, they're asymptomatic. And sometimes with massive ingestions, you may see some decreased level of consciousness and metabolic acidosis, but this is exceedingly rare. And a good example of this is I had one patient who was, the guy was down on his luck. I think he was having trouble making ends meet for his family, and so he said, I'm gonna kill myself with a bunch of Tylenol. And so he ended up ingesting a whole bottle of 500 milligram tablets, you can get from Costco. And so he ingested a whole ton of it, and he said, okay, I'm doing myself in. So he goes to sleep, wakes up the next day, and he's like, I survived. This is great. Must be a sign, right? So he said, I'm going to go look this up. So he goes to the library, looks up acetaminophen toxicity, and he's like, oh no, this is just starting. And so by the time he got to us, he was probably about 36 hours out, and he was yellow from head to toe. He looked about as yellow as a school bus, right? Just from the amount of damage he's already doing, the bilirubin that was starting to accumulate. So he came in very, very sick. And so I'll kind of describe more of this case as we go through. But he was already in the stage 2 period, right? So 24 to 36 hours after the ingestion, this is where you start to see the transaminase elevations occur, right? So your LFT, AST, ALT are going to start to go up. This is where you can also start to see PT-INR get affected. Why do you think PT-INR is affected here? Right, the liver's making clotting factors, right? So if you're not making the clotting factors, you're starting to see the PT-INR go up, right? So this guy has already had an INR of, say, like 3.5 at this point, right? Wasn't bleeding or anything, but he definitely has an increased INR already. His AST, ALT were probably in 3,000 or 4,000 range at this point, and they were still climbing, right? So you can see tens of thousands AST and ALT for some of these guys. Also start to see potentially acidosis develop, so you can have lactate starting to go up. And then for really large ingestions like him, he was starting to enter this kind of 3rd stage kind of prematurely. So again, 72, usually 96 hours out, this is where you start to see further increases in transaminases. You may see some patients get so progressive in their hepatic injury that the LFTs start to drop again. And so normally you see the LFTs drop, you're like, oh, that's a good sign. For some patients, if their INR is still going up, that could just be they have no more enzymes to release anymore, right? So that can actually be kind of a pretty bad sign there. But this is where the jaundice happens. You can have renal failure associated with that NAPKI affecting the kidney cells, hepatic encephalopathy, acidosis. And then if they're going to die, they typically will die from hepatic failure, usually within 3 to 5 days or so. And if they make it through that stage, they can have this recovery phase, and it may take weeks to months before the liver kind of gets back to its baseline. But again, liver's kind of amazing the fact it's able to regenerate itself so well, and so you can have patients who get very, very sick. So like this guy, we ended up treating with an antidote, but he was able to make a full recovery. So he actually ended up doing very, very well, despite how sick he initially presented. So again, you always want to assess your risk for Tylenol toxicity. So again, the history is probably going to be unreliable, so you may have some issues there. But we're going to be following our acetaminophen levels. Okay, so this is going to be one of the important things we'll look at here. And then basically you're going to base off the amount that's ingested. You guys okay? Oh, there's a bug. Okay. Need Curtis to go kill it again, like the last one. Yeah. Okay. Anyway, so basically the cut point here is if you have an adult with a history of more than 7.5 grams or a child with more than 150 to say 200 mg per kilo, those patients are more at risk and they need to be evaluated. Okay. We evaluate them. We use the Rumack-Matthew nomogram. You guys ever seen this before? So if it's very common, huh? All the time. I look at this one. I have a keep it on a poster above my bed so I can look at it when I'm going to sleep. Unfortunately, Matthew's dead, but Dr. Rumack is actually still alive. And so, like, I remember when I got to meet him at the first Tox conference I went to, it was like meeting, like, I don't know, Bon Jovi or somebody. Like, it was just like, it was super cool. It was just like, you're the guy. Yeah, can you sign my nomogram, please? Like, he's a very nice old man. He has a nice bow tie and stuff. But anyway, so they basically were working with studies where they were looking at acetaminophen levels and looking at when toxicity was occurring, and they came up with this nomogram basically, where based on the time since your ingestion of acetaminophen and based on the level of Tylenol that you get in the system, you can assess whether or not they're at risk for developing hepatotoxicity. Okay, so the big things with this nomogram, and a lot of people use this inappropriately, but the intent for this thing is to be used with a single ingestion, and you know exactly when the ingestion occurred, right? So if the history is unreliable, can't really use this. It's not going to be all that effective. But basically what you would say is, okay, the time frame starts at 4 hours. So you start here. So again, if your patient shows up 2 hours after the ingestion, you don't necessarily need to draw a level yet. You can wait till that first 4 hour mark, okay? So wait till 4 hours, you draw a level here, and if they end up getting a level of 150 or higher, then we know that they are at risk for developing hepatotoxicity, and that means they're going to be getting treatment. Okay, so if they're above this line, that means yes, we're going to go ahead and treat them. So if they came in 8 hours and their level was say around 75 or so, then yeah, we're going to go ahead and treat them, or they're above that. If they came in at 12 hours and they're around 37.5, so basically it's going off of a 4-hour half-life of the Tylenol. But if they go above that level, yes, we need to treat them with the antidote. And do you guys know what the antidote is? N-acetylcysteine or Mucomyst. That's what we're going to be giving for those patients. So that makes sense how that works? Okay, so in some patients that, you know, come in and say, okay, well, you know, it's very easy if they have a 4-hour level that's like 300, and you're like, okay, yeah, absolutely, let's go ahead and treat them. But, you know, say they come in, they have a level of, say, 30, and we don't know when the ingestion occurred. That gets to be much more difficult, and so you find in a lot of cases we end up over-treating probably more than anything else because we, again, it's a very benign medication that we're giving as an antidote, and hopefully we can stave off any the significant, you know, sequelae of this hepatic damage. So again, we probably end up over-treating more than we should, but it's in order to prevent the damage from occurring. Okay, so again, as far as monitoring goes, you're looking at your acetaminophen levels. Again, typically you're going to be measuring levels. Once you decide to treat, you don't really need to monitor levels routinely. Basically, we'll go ahead and get levels every 24 hours or so to make sure they get to an undetectable point. You're monitoring your LFTs and trending those and seeing where they're going. PTINR, that's really only going to be if you start to see the hepatic damage being done. So if your LFTs are starting to go up, you know some damage is happening, then you can look at your PTINR to see where that's going. And then obviously a basic metabolic panel to look for acidosis and other you know, electrolytes and glucose and all that good stuff.
Administering the Mucomyst, I know that we give it to kids.
I'll show that regimen in just a moment. Yep. So again, management is mostly going to be the ABCs. Again, look at other concomitant ingestions they have. If they had a bunch of opioids on board or anticholinergics, you kind of manage that in the meantime. You can use activated charcoal for this if they present within the hour or potentially 2 hours. If it was an opioid co-ingestion or if it was an anticholinergic there. Manage their hyperglycemia because again, gluconeogenesis is happening primarily in what organ? The liver, right? So if their liver's going kaput, then you need to give them some dextrose, right? So we may need to deal with that. As far as coagulopathy goes, we will give them kind of prophylactic vitamin K to kind of help work with some of those clotting factors, but in some cases, you may need to give them supplemental blood products in order to help kind of replace those factors. It's not common, but you may need to, depending if they're bleeding or not. And then in some cases, you may actually think about transplant. I'm not going to make you memorize the indications here, but some of the things you're going to look at to see whether a patient would be a candidate would be things like they have very severe acidosis, if they have, you know, things like their PT is increasing, their serum creatinine is elevated, or they have this encephalopathy that develops. That could all be signs of very poor outcomes, and so we can actually evaluate them for having liver transplants. Obviously, what's kind of the ethical problem with giving a liver transplant to someone like this? They try to kill themselves, right? So that's kind of the thing you run into. So you have to look at the scenario to see, like, okay, well, you know, was a person who is, you know, obviously trying to harm themselves and they're not going to be able to really take care of themselves after this, you know, are they going to be a good candidate or not? Some patients are doing this not intentionally, right? So consider the patient has chronic pain issues. They don't realize that they've put themselves in this situation. They may more be like a better candidate. So it's not done commonly, but occasionally you may need to consider transplant. But instead, what we're going to do is use our antidote, which is going to be N-acetylcysteine. And you can see where N-acetylcysteine is working in several places here. Basically what NAC is doing, you see NAC here, you see NAC here, and you can see NAC here, right? So basically it's being a donor, it's providing the, helping to regenerate those pathways that our body normally would use to detoxify acetaminophen. So it can help to provide sulfur groups here in order to help with this sulfation pathway. And so if you imagine it's donating sulfur groups, what does it smell like? Rotten eggs, absolutely. Yeah, so NAC is a very, very poor smelling drug. Actually, it just smells like regular eggs to me now because I got kind of desensitized to it over years of working in tox. But yeah, a lot of patients don't like the smell of it. You'll find that it also acts as a glutathione precursor and a donator, so you can actually help to regenerate this glutathione pathway to help detoxify NAPK. And then also works as a free radical scavenger, so it actually helps to deal with the NAPK that kind of gets out and then working on other cells can help to deal with some of that damage. So it's really kind of a wonder drug in a lot of cases. So you can see the mechanism there. And the nice thing with NAC is that within, if it's given within 8 hours after the ingestion, it's considered to be 100% effective, meaning your patient's not going to die, right? So it's very, very important to make sure that we can get as good a history as we can and decide whether we should treat. And the sooner, the better, right? So hopefully within an 8-hour period. We will still give it way after that. So for instance, that one guy that came in, he's already kind of yellow from head to toe, we actually were giving him NAC well after a normal kind of treatment regimen would have been, just because we know it has those kind of nice effects of binding up those free radicals and helping to kind of detoxify him. So just real briefly, so we have two forms of N-acetylcysteine. We have the IV form, which is called Acetadote, and then you have the oral form, which is called Mucomyst. Do you guys know where else you might use Mucomyst at? You know. Yeah, it's a mucolytic as a respiratory agent, helps to break down mucus a little bit better for some of your patients. The big differences here is that they're both equally efficacious. They can both work very well. The IV form is obviously going to be much more expensive because brand name, and safety-wise, they're pretty much comparable. Both are very, very safe to administer. The dosing we were talking about here is that you have a couple different dosing that you might use. I'm not going to make you memorize this, just realize that there's some differences here. So for the IV form, we have this 21-hour protocol. We're actually going to give 150 milligrams per kilogram as a bolus over 1 hour, and then you follow up with this 20-hour infusion where you're giving a few different rates here. This is very error prone, having to make sure that the nurse goes back in and reprograms it appropriately. So there's lots of problems with that. And then we have the oral 72-hour protocol. Basically, you give a bolus dose up front once, 140 mg per kilo, and then you're given 70 mg per kilo every 4 hours afterwards. That way, it goes ahead and covers them for about 3 days or so. And obviously, you can tell there's kind of a difference in the time frame there, 21 hours versus 72 hours. So there are some occasions where actually we'll cut the oral one short early once we realize that they're not really having any further damage. But for those patients who are still toxic even after we've given them a full course, we will continue the NAC out indefinitely until they start to recover. So the things we're looking for is we want the LFTs to start to come down, we want the INR to normalize, and we want the acetaminophen to be undetectable. Okay, those are the three kind of cut points we're using to make sure that our patient is okay to stop giving NAC. Again, do the LFTs have to be normal? No, we just want them to be on a normal trend, right? Just showing that they're starting to recover and they're not really leaching out any more enzymes. Okay, so any questions on acetaminophen? If not, you guys can slither your way back on Thursday and we'll talk about our envenomations.